Dear friends, welcome to this short presentation on applied surgical anatomy of the inguinal canal. I am Dr. Lakshman, a surgeon practicing in Bangalore. It is important to understand the inguinal canal because the inguinal hernia is one of the commonest general surgical operations performed by a surgeon. It is also an operation where beginners learn the fundamentals of tissue dissection, and to make a good beginning, a thorough understanding of the anatomy of that area is an essential requirement. The other interesting thing about the inguinal canal and the inguinal area is that the perspective of the same pathology, namely the inguinal hernia, is very different when you approach it either from an open operation or through a laparoscopic procedure. And so it is interesting and important to understand the two completely different perspectives of the same pathology. To understand the inguinal anatomy, one must understand the anatomy of the anterior abdominal wall, because after all, the inguinal area of the inguinal canal is the inferior limit of the anterior abdominal wall. These pictures clearly demonstrate the layers of the abdominal wall, and it is familiar to most of us. In the supraumbilical and immediately inferior to the umbilical area, the three layers, lateral layers as we call them, the external oblique, the internal oblique, and the transversus abdominis, form the lateral part, and when they approach the rectus abdominis muscle, the external oblique aponeurosis goes in front of the rectus abdominis. The internal oblique splits into two and goes on either side, the front and the back of the rectus abdominis, and the transversus abdominis goes behind the rectus muscle, forming the rectus sheath, and they meet again in the midline, forming the linea alba. About 4 to 5 centimeters inferior to the umbilicus, the arrangement changes at the level of the arcuate line, where all the three layers of the abdominal wall go in front of the rectus. So essentially, in the lower two-thirds of the area between the umbilicus and the pubis, there is no posterior sheath, and all you have is the peritoneum, extraperitoneal fat, and the transversalis fascia. The three structures shown here are the obliterated urachus forming the median umbilical ligament, and the two obliterated umbilical arteries forming the medial umbilical ligament. This is a dissection of the anterior abdominal wall. Several layers are opened out. One can see that the external oblique has been removed here. You have the rectus muscle, the linea alba coming there, and the arcuate line or the linea semilunaris is very well seen here, inferior to the umbilicus. The inferior epigastric artery is a content of the rectus sheath. It is shown here, and over here is the cut edge of the internal oblique and the transversus abdominis muscle going there. The lower end, this is the area of interest for us, and that is the inguinal canal. The inguinal canal is a 4 to 5 centimeter long structure in the adult, extending from the internal ring in the transversalis fascia to the external ring, which is an opening in the external oblique aponeurosis. It is walled off anteriorly by the external oblique aponeurosis, and its posterior and posterior-superior limit is the conjoined tendon, which is the tendon formed by the internal oblique and the transversus abdominis, which initially forms the posterior-superior limit of the inguinal canal, curving downwards across the structures of the inguinal canal or the spermatic cord, and forms the posterior wall at the back on the medial side, which is about this area. The cord itself is formed by the various layers of the abdominal wall and will be described subsequently. It is important to know that essentially the cord is formed by the extrusion or extensions of the layers of the abdominal wall. This is a picture that depicts the formation of the cord and its several layers. One can appreciate that the core of the cord is this obliterated peritoneal extension of the tunica. If it persists, one gets an indirect hernia. The direct hernia would be a weakness in this area of the abdominal wall. The internal spermatic fascia is formed by an extrusion or an extension of the transversalis fascia. The extension of the internal oblique becomes the cremaster muscle, and an extension of the external oblique forms the external spermatic fascia. These of course form the layers of the scrotum as well, as they extend well into the scrotum. At this point, it is essential to understand the contents of the cord. The cord mainly has the vas deferens, the testicular vessels, the pampiniform plexus of veins, the lymphatics, and two important nerves: the genital branch of the genitofemoral nerve, which enters it through the internal ring, and the ilioinguinal nerve, which enters the cord by coming through the internal oblique a little anterior to the internal ring. It is important for surgeons to remember that the ilioinguinal nerve is the nerve that is prone to damage, and if one includes it in a suture, that would be a source of chronic pain to the patient. But it's perfectly logical, if it is coming in the way, to sacrifice the nerve through a clean cut at its point of entry into the inguinal canal. I repeat, it is better to sacrifice the nerve rather than damage it, crush it, or stitch it up. This is a laparoscopic perspective of the inguinal area. One can see the midline structure, the bladder, the vas deferens, and seminal vesicles here. This is the cut end of the ureter. At the lower end of the anterior abdominal wall, on the posterior view, one can see the obliterated urachus, and this fold of peritoneum is called the median umbilical ligament. This is the medial umbilical ligament, which is the obliterated umbilical artery, and the inferior epigastric artery coming up that way is referred to as the lateral ligament. The area of interest for the surgeon is the so-called Hasselback triangle, which is bordered by the lateral border of the rectus there, the inguinal ligament up here, which is the upturned inferior edge of the external oblique, and the inferior epigastric artery. This triangle is the Hasselback triangle, and the direct inguinal hernia occurs at this level. The indirect hernia will go through the internal ring, which is here, and the femoral hernia is above the pubic symphysis, above the pubic ramus rather, and below the inguinal ligament, which is that, and occurs here in the femoral canal, just medial to the femoral vein. It is important to understand the vascular structures that are at risk when we do a laparoscopic repair, which is essentially the femoral vein and the femoral artery. And this area, which is delineated by the vas deferens coming this way and the testicular vessels which go that way, and that the apex of that triangle where you have the iliac vessels going underneath the inguinal ligament forming the femoral vessels is called the triangle of doom, where these structures are at risk at the time of dissection. This is the real life photograph of how the anatomy looks. Looks very different in real life, but one gets used to this as one gains experience. This is the median umbilical ligament, and this is the medial umbilical ligament, and just lateral to that is a small defect, which is a direct defect. In this particular patient, the median umbilical ligament is seen, the medial umbilical ligament is hardly seen, and here is a medially displaced inferior epigastric vessel or the lateral ligament with an indirect defect out there. This gives a closer view of the areas of interest. This is the inguinal ligament from the posterior aspect, extending from the pubic tubercle here to the anterior superior iliac spine out there. And this is the lacunar ligament, which is a horizontal deflection of fibrous tissue from the inguinal ligament onto the pubic ramus, and the lateral curvy linear edge of the lacular ligament forms the medial end of the femoral canal, and the lateral part of the femoral canal is formed by the femoral vein, and so a femoral hernia occurs here inferior to the inguinal ligament, and a direct hernia occurs here superior to the inguinal ligament. And this is the internal ring, which is a defect in the transversalis fascia, as we mentioned earlier, with the spermatic cord, the beginning of a spermatic cord with the vas deferens, this structure entering this, the inguinal canal, and this is the testicular vessels going that way, and this is the triangle of doom, which will be shown in another operative photograph later, where the femoral vessels are located. It's also important to understand the so-called rectangle of pain, which is down there. Most of the nerves that come through here come through inferior to the iliotibial tract. This is the iliotibial tract, and it comes inferior to the iliotibial tract. You can see these nerves being shown here. So if you are using fixators like tackers, they should always be put above the iliotibial tract or somewhere in this area. If they are deployed below the iliotibial tract, then you are likely to have an increased incidence of post-operative pain. This is the real life view. One can see bilateral direct defects. This is the hernia over there. The medial umbilical ligament is seen, and in this patient, the median umbilical ligament is hardly seen. You would expect this to be the area where you see that, and here is the inferior epigastric vessel. And the potential for an indirect hernia, which is this area. This is a picture of an indirect defect, which is here. You can see that the defect is pretty big with omentum as a content. And what it has done is it has pushed the inferior epigastric vessel medially. This is the vessel coming up there, and the area of the direct defect, which is the Hasselbalch triangle, is very much narrow, and this is the medial umbilical ligament, the obliterated umbilical artery. So one can see that there can be variations in patients as we see different situations in different patients. This is a picture depicting the triangle of doom, which is what one has to be very careful about when we do an inguinal dissection at laparoscopy. This is the bladder, the midline area, and this is the medial umbilical ligament. One would expect the inferior epigastric artery to be going up this way, and you can see the vas through the peritoneum coming down that way, going medially and inferiorly. These are the testicular vessels, which are quite commonly seen. This would be the internal ring or the area of the indirect hernia. This would be the area of the direct hernia. You can see a little depression here, which is a small weakness in the posterior wall. But this is the triangle of doom. When you dissect in this area, one has to be aware that the external iliac vessels are right here, just under the peritoneum. Essentially, this completes the surgical anatomy of the inguinal canal. What we have to remember is that we have to be careful about the placement as well as the anchoring of the mesh. Please note that in a laparoscopic hernia, you cover the whole of what is called the myopectineal orifice. Thank you very much for your patient listening. I would very much welcome comments and queries from all of you. Please feel free to write to me at klakshman58@gmail.com. Thank you very much once again. Goodbye.